It's good. Can we check that that chat function is working for people online? Can you just put a little message to say where you're from? It's good. Can we check that that chat function is working? Perfect. That's YouTube is working. Now, I'm going to be a little bit naughty and share a little video that we've just hot off the press from Saudi. And then we can start our webinar if I find the video, because I'm a bit. Oh, we already have 74 messages on the chat. We'll wait for another minute or two before we start. And let me see. The first eye breast book cadaveric dissection. Welcome to Riyadh to the first eye breast book cadaveric dissection course.
That's a very, very big meeting that they do here in the Middle East. It's one of the biggest I've seen. The course is unique in the way of giving a large amount of knowledge and the techniques.
Applicants will have a hands-on experience of different reconstructive techniques, including oncoplastic techniques, the perforator flaps, utilization of ABM in prepectoral or rectopectoral breast reconstruction.
Saudi Arabia is upcoming in oncoplastic. Important in the Middle East to have this concept, and it was a very great opportunity to exchange the experience between the faculties and the attendees.
It will be a pleasure to share my ideas with fellow colleagues and fellow students.
I think for the future, it means a lot to this area to improve the surgical skills.
It's amazing to see so many enthusiastic young surgeons from the region enjoying this learning experience.
It's an amazing opportunity to be able to give some hands-on experience and tips and tricks to the trainees here.
We had enthusiastic and large participation, very, very high level cadaveric courses where we are teaching to our attendees techniques in skin sparing and nipple sparing mastectomies, oncoplastic breast conserving surgery, and chest wall perforator flaps.
It's been an amazing experience to be a part of this, and hands-on experience like this is difficult to find.
It's been a great few days. We've seen very enthusiastic young surgical trainees and fellows really digesting everything from lectures to the cadaveric demonstrations and workshops. And it's really inspiring to see young people very excited about developing their careers and skills.
Looking forward for this course for many years thereafter.
I was so excited to be a part of the family.
And we look forward to having more in the future.
This will be the first of many meetings.
This has been an amazing 3 days. I would like to thank all the organizing committee, Dr. Huda Nu'mani, Dr. Yazad Masannat, and all of the amazing instructors.
Thank you so much for coming to Saudi Arabia. Shukran.
So thank you, everyone. So I've just flew back from Saudi. We had a lovely course. We had about 200 people from all across the Middle East coming for a lecture-based course, and we had about 60 plus people in the cadaveric dissection course. Great experience. Keep an eye on the newsletters for future courses, because I don't think this is the first one. It's great to see that there's nearly 500 people online already, and there's more than 100 messages on the chat function. Remember that if you have any question, please put it on the Q&A section. Otherwise, we will not see that. Now, we have a great webinar today. It's a purely British lineup with the mainly talking about upfront surgery in the positive axilla. And mainly, this is like a platform talking about the future TADPOLE study that the team is arranging, led by Shelley, and looking forward for this study when it opens. Now we'll have lots of talks, and we'll start with the talks, and then after that we'll have the discussion. I think the first talk will be mainly by Shelley. Shelley Potter is one of the professors in Bristol, and she's going to give an overview about upfront surgery. Shelley, the next 10-15 minutes is all yours, and I hope that your computer was not going to update now. I think you're on mute, Shelley.
Yeah, thank you very much, Yazan. As usual, I'm proving my complete inadequacy in using any form of IT. So thank you very much for this opportunity, Yazan, to talk about the background to primary TAD and the TADPOLE study. So as we all know, about 1 in 4 women at presentation have node-positive breast cancer. And in the UK, our national guidelines state that all these patients should be offered an axillary lymph node clearance, irrespective of how many lymph nodes are involved. And while most of us have absolutely no problem with offering an axillary clearance in patients with a very heavy nodal burden, we are increasingly feeling uncomfortable about clearing patients who have only 1 to 2 positive lymph nodes. And we've known since the BO4 study from Bernie Fisher, so for over 30 years, that there is no benefit from an oncological perspective to performing more axillary surgery in patients with low volume disease. And these graphs are from the recent Early Breast Cancer Trialists Collaborative Group meta-analysis that shows there's no oncological benefit, either in terms of local regional recurrence or distant recurrence, in patients having more versus less axillary surgery. But what we do know is that axillary lymph node clearance is a highly morbid procedure. Up to 30% of patients have life-changing, lifelong lymphedema that can profoundly impact their quality of life. More than 20% have chronic pain, and more have problems with their shoulder function. And in our recent James Lind priority setting partnership in breast cancer surgery, avoiding axillary node clearance was the #1 research priority amongst more than 200 patients and 100 professionals who participated in this process. So moving away from axillary node clearance where it can be avoided is really what we'd like to do. And although we recommend axillary lymph node clearance in patients with 1 to 2 positive nodes in the UK, this isn't the case worldwide. And these are the National Comprehensive Cancer Network guidelines from North America, who recommend that we should be doing a sentinel node biopsy in patients who have clinically node negative disease, and possibly those who have 1 to 2 positive lymph nodes on imaging. And this is all based on the results of the AZACOG-Z 11 trial, which showed no difference in disease-free survival or overall survival in patients with a positive sentinel node, either having sentinel node biopsy alone or axillary lymph node dissection. And North American guidelines were changed on the basis of these data. But internationally, and particularly in Europe, the Z11 trial was heavily criticised, as despite being pioneering and world-leading, there were several methodological problems with it. It was very slow to recruit, and only recruited 50% of its target. The event rate was lower than expected, so it was underpowered. There was no radiotherapy quality assurance, so we can't be sure that in the patients who had sentinel node only, that the radiation oncologists didn't give them a bit more radiotherapy to compensate. There was poor adherence to the treatment allocation, a high loss to follow-up, and the Z11 trial, which recruited clinically node negative patients, didn't reflect UK practice. And as a result, there have been multiple international Z11 confirmatory trials, including POSNOC in the UK, CENIMAC, BOOG, INSEMA, all of which were essentially asking the same question. And all these trials include clinically node negative patients. Some of them involve ultrasound, but the trial populations are CN0 patients. But in the UK, all of our patients have axillary ultrasound as part of their diagnostic workup for staging, with biopsy of any abnormal or equivocal nodes. And Nisha will tell us more about that later. So we know up front whether our patients are node positive or node negative. So what about sentinel node biopsy in patients we know up front are node positive? Well, we know that patients with ultrasound detected node positive disease have a higher burden of disease than those with clinically node negative disease. There are concerns about a false negative with a sentinel node biopsy, because if the cancer is involving the lymph nodes, it may disrupt the lymphatics. So the dye and the tracer might miss the involved lymph nodes. This may mean that we leave involved lymph nodes behind. So I think we would be cautious in the UK about doing a sentinel node biopsy alone in patients with known upfront positive nodes having primary surgery. So what about targeted axillary dissection? Well, targeted axillary dissection is a sentinel node biopsy in combination with removal of the clipped or localized node. And this has become the standard of care in the neoadjuvant setting for patients converting from clinically node positive to node negative following treatment. And there have been multiple studies that show that removing the clipped node in combination with a sentinel node dramatically reduces the false negative rate to within acceptable levels. So could a TAD, a targeted axillary dissection, be a good alternative to axillary lymph node clearance in patients with low volume disease having primary or upfront surgery? So the first thing we wanted to do was determine what the current practice was in the UK. We have NICE guidelines, but those may not reflect practice. So we did a national practice survey. And what this showed was that in the UK, 80% of units approximately were still doing axillary node clearance for patients with 1 to 2 positive nodes on ultrasound who are clinically node negative. Comparatively few were doing targeted axillary dissection or sentinel node biopsy alone in this population. When we asked them who they were doing targeted axillary dissection in, approximately 50% were doing them in selected patients, and approximately half the units were doing them in all comers with low volume node positive disease. But there's currently no evidence for the use of targeted axillary dissection in patients having upfront surgery. So we designed the TADPOLE study, which is looking to compare targeted axillary dissection and axillary node clearance in patients with positive axillary lymph nodes having primary surgery. And it's a pragmatic multi-center phase 3 trial. It aims to assess whether in patients with breast cancer with low volume axillary nodal disease, defined as clinically node negative with 1 to 2 positive nodes on ultrasound, having primary surgery, so not neoadjuvant, those who are having surgery as their first treatment, compared with axillary node clearance, targeted axillary dissection leads to significantly less lymphedema at 12 months, measured objectively with our measurements and patient self-report through questionnaires, without leading to unacceptable rates of local regional recurrence at 5 years, and is cost effective. TADPOLE aims to test the hypothesis that TAD, so surgery alone, is sufficient local regional treatment for patients with low volume nodal disease. So TADPOLE is internationally novel in that it's de-escalating axillary treatment, looking at surgery, as axillary radiotherapy will be prohibited in the trial. So quite a lot of centres who have moved to doing TAD in patients having surgery combine it with radiotherapy. In TADPOLE, it will be TAD with no radiotherapy. And this is the schema for the TADPOLE trial. So patients with 1 to 2 positive nodes, biopsy confirmed on ultrasound, who are clinically node negative, will be randomised 2 to 1. So patients are twice as likely to get TAD as they are to axillary node clearance. And they will be followed up at 1 year for lymphedema and 5 years for local regional recurrence. And we're aiming to recruit 861 participants. We're planning to include adults over the age of 18 with unilateral T1 to T2 breast cancer with biopsy-proven low-volume nodal disease, so clinically node negative with 1 to 2 positive nodes on ultrasound who are having primary surgery. We're excluding people with T3 disease or those with 3 or more nodes on ultrasound or clinically abnormal nodes, because we want to move away from those who will want nodal radiotherapy. We're not including lobular cancers because of the difficulty in accurately assessing the axilla, recurrent breast cancer, previous surgery, and those patients having neoadjuvant therapy. And TADPOLE really is a team. It does really take a village to run a trial, and we have a vast array of expertise. We have radiology, we have clinical and medical oncologists, we have methodologists, and most importantly, we have our patients who helped us design the study. And a lot of local regional trials, so trials of surgery and radiotherapy, are criticised because unlike drugs, surgery and radiotherapy and radiology are complex interventions, so they are operator dependent. So we are embedding quality assurance at the very heart of the TADPOLE trial. We've got radiology quality assurance led by Nisha Sharma. We've got surgical quality assurance, and we've done the TADPOLE Together project to agree how to perform a primary TAD and how it should be monitored within the trial. And we've also got radiotherapy quality assurance with the RTTQA programme involved. So we will know exactly what radiotherapy the participants in TADPOLE have had. So when it comes to reporting, we can be confident that the TAD group had TAD with no radiotherapy. And hopefully this will avoid many of the criticisms that trials have had. And this is the TADPOLE Together project that has now been completed. We agreed how to do a primary targeted axillary dissection using an international consensus process, which Dr. Ruth Mullen, who was one of our foundation programme Doctors was heavily involved in. We developed a long list of potential components of TAD through the literature and expert opinions. We did 2 rounds of an international Delphi survey with more than 200 surgeons, many of whom were experts in performing TAD. And then we held a consensus meeting to agree exactly how a TAD should be performed and how we should monitor it within the trial. And we're also working with a group of TADPOLE champions who are expert surgeon innovators in the UK, who have experience of introducing new procedures and primary TAD, who will help us share the learning and ensure that primary targeted axillary dissection is implemented in a standardised way throughout the UK within the trial. And this table basically summarised what we've agreed. It looks very complicated, but essentially we've agreed that a primary TAD has 7 steps. It involves localising the involved node prior to surgery, checking you've localised it, removing the involved node in combination with a sentinel node biopsy, confirming you've taken the node out and have taken out any palpably abnormal nodes. Everything else is flexible and as per unit practice. So we hope this is sufficiently standardised, but also sufficiently light touch for this to be implemented in practice. So how are we getting on with TADPOLE? Well, we've secured funding from the NIHR HTA funding stream in April of last year. We've completed the TADPOLE Together consensus process. We've written the protocol and study documentation, and we're currently going through regulatory approvals. TADPOLE aims to open in summer 2025, and we're also working with the Australians to open in Australia and New Zealand, and we hope also to open in Europe, which would be fantastic if the tadpoles were swimming worldwide. So I think the future to surgery in patients with node-positive disease probably is less, and targeted axillary dissection will be part of that. But to change practice, we need evidence from large-scale, high-quality randomized trials such as TADPOLE. So we need you. If you're working at a UK unit and you want to get involved in TADPOLE, please do contact us or scan the QR code to fill in the expression of interest, and please do get in touch. TADPOLE needs you to help us generate the evidence we need to change practice. Thank you very much.
That's a great talk. Thank you for that, Shelley. And it's important to have those trials because we need evidence, because certain places are de-escalating, and we will talk about experiences also. Henry will talk about that later. And I think this is the future, but we need more evidence to confirm that this is the future. And if anybody does not have the contact for Shelley or anything, just email me at info@ipressbook.com and I will connect you with the study if you want to join from any part of the world. Now, that's a beautiful overview of the TADPOLE. Now, what we need to start taking different specialties separately and see how we can look at that. And the first talk will be about axillary imaging and localizing the nodes for primary TAD. And we have Nisha Sharma. So Nisha will have the next 10-15 minutes talking about that.
Thank you, Yazan. So I'm just sharing my screen, so I'm just waiting to see that you can see that.
That's perfect, Nisha.
Wonderful. So I'm going to, in the context of targeted axillary dissection, talk about the role of imaging and how we make this successful. So I'm Dr. Nisha Sharma. I'm a consultant breast radiologist working at Leeds Teaching Hospital NHS Trust. Oh, my slides. There we go. So first of all, in the context of a biopsy proven cancer or suspected cancer in the breast, in the UK, we would always scan the ipsilateral axilla. So you want to scan the axilla, and you will have a local protocol as to what you determine a node to be normal or abnormal. And this is often based on the morphology of the node, but also the cortical thickness. And one thing that we do know in the UK, that the cortical thickness determining whether a node is normal or abnormal is variable across different centres in the UK. So according to your local protocol, if you have a cortical thickness of 2 millimeters, which above would indicate the node is abnormal, then that's what you would classify as your node as being abnormal. Now, often when we classify lymph nodes, we may say the lymph node looks indeterminate or equivocal, we may say it looks suspicious, or we may say it looks obviously malignant. Either 3 of those would determine the node to be abnormal. And what's very important is when you're imaging and the axilla that you have to document the number of abnormal nodes that you can see, because this will determine if they're eligible for TADPOLE or not. And what we want to do is biopsy the most abnormal node. And if that's not possible, we then need to biopsy the most abnormal node that's accessible for biopsy. Now, we know that when needling the node, this can either be with conventional 14-gauge core biopsy or by needle aspiration. And again, because we want to make TADPOLE accessible to all, you can either use FNA or core biopsy, but core biopsy is considered the gold standard. It's very important that we take static images which demonstrate the abnormal nodes. And when we've biopsied the node, that we actually take images of the needle through the node. And this is because if the patient is coming back because we need to localize the node or put in a clip, then we can make sure that we've gone for the right node. And remember, only one node needs to be biopsied. So this is an axillary ultrasound of the left axilla. And here what we have are two abnormal nodes. The fatty hilum is no longer visible. And this is a node that we would classify as U5 abnormal. But we've got one normal node also within the axilla. So when reporting this, we would document that we have two abnormal nodes within the axilla, which means that this would be eligible for TADPOLE. Now, we know that once we've biopsied the node, when do you put in the marker clip? Now, in the context of TAD, the clip can be placed at the time of biopsy. And again, you would want to know what your local protocol is. Is that what you do all the time? But there's no rush to place the marker clip because you will be going back to localize the node. Because remember, these patients are not having neoadjuvant chemotherapy. We wouldn't recommend putting in a non-wire localizer at the time of biopsy because, first of all, you don't know if the patient's eligible for TAD. You don't have biopsy confirmation that the node is malignant. So remember that when you place a non-wire localizer, that has to be at a separate appointment, and that is once you've had multidisciplinary discussion that the patient is eligible for TAD, and you know that. And the other important point you need to know is whether the patient is going to have a breast MRI. So in the context that the patient has a breast cancer, we know that they've got biopsy proven cancer. You may want to do a breast MRI, not because for neoadjuvant chemotherapy, because remember, these patients are not going through neoadjuvant chemotherapy, but you may want a breast MRI to determine disease extent within the breast. And this is often if they're invasive lobular cancer, or if the breast is dense and you're unable to accurately size the tumour in the breast. And also if you want to exclude multifocal, multicentric disease. So there are two scenarios that you could have. If you have a patient that has two or less abnormal nodes, eligible for TADPOLE, and breast MRI is not needed, then the biopsy proven node that's shown cancer could be localized with a non-wire localizer, so dependent on what you use within your department. If, however, the patient is having a breast MRI for the reasons that I've explained before, then you want to rediscuss the findings of the breast MRI at your multidisciplinary meeting. Because sometimes when you do a breast MRI, you do get good visualization of the axilla, and you may determine that there are actually more abnormal nodes than you'd seen in conventional ultrasound, which may make the patient ineligible for TADPOLE. Now, after the breast MRI, and they're still eligible for TADPOLE after MDM discussion, then you can go back and mark the node. And again, you can use a non-wire localizer if that's available in your unit. If it's not, then you would place a marker clip, because the way you would localize the node is using a hook wire. So this is an example. This is the same case with an abnormal node that we've actually biopsied. The needle's going through the node, and we've put in a marker clip. And in this case, it's a twirl marker clip, which is visible under ultrasound and is very easily identifiable by the radiologist. So localizing the node. So non-wire localizers There are many in the market, and often if you're using non-wire localizers within your own unit, you'll often use the same non-wire localizer for the axilla. So for example, if you're using MagSeed to localize the breast, you can use MagSeed for the axilla, and it's the same with the Sabi Scout and the RFID tags. If you're not using a non-wire localizer, then what you would want to do is a wire localization on the day. Wires are tricky. So because in the UK we have moved away from using wires most often, it's a lot easier to place a non-wire localizer in the node than placing a wire. You want to make sure, as Shelley had stated, that you x-ray your sample. So once you've performed a targeted axillary dissection, you should x-ray your sample because you want to confirm that you've removed the node that contains the marker clip. And this is the MagSeed that we had used to localize the node. And this is the specimen x-ray. And we can confirm that the node that was biopsied and clipped has been excised. And we've also taken out the non-wire localizer. So in summary, in the context of an ipsilateral, in the context of a biopsy probing cancer or suspected breast cancer, we will always scan the axilla. Document the number of abnormal nodes, whether they're equivocal, suspicious, or abnormal. You want to biopsy the most abnormal node. You can place a clip at the time, or you can do this post-MDM discussion, as you may actually not need to clip the node because you can put in a non-wire localizer. The question you want to ask is staging breast MRI required? If yes, then perform the breast MRI first and then discuss the findings at the multidisciplinary meeting to confirm that the patient is still eligible. The non-wire localizer will be inserted prior to the TAD surgery, but after breast MRI if this is being performed, because it does cause significant artifact on breast MRI. And always make sure you x-ray the sample to ensure the marked node has been excised. Thank you.
Perfect. That's lovely talk. Thank you for that, Nisha. There's lots of things on question and answer. There's already about 24 questions and Shelley has gone through the first. So please have a look at those. If there is anything you want to answer live, just click on that. I'm having lots of messages and lots of WhatsApps asking about Ricardo. Ricardo is flying back from Turkey. We just had a cadaveric dissection course in Saudi Arabia, and Ricardo was part of that as an iBreast book tutor, and he's coming back from Turkey, so he's not going to be able to join us today, unfortunately. So there's no Spanish channel today, but there's only a Russian channel today. And people are asking about recordings. Of course, like any iBreast book webinar, it is on the YouTube channel. It will be available there for a good few weeks' time. And if there is any issues accessing the channel, just let me know. I'm sharing the link for, many of you are on the WhatsApp groups already, but also I'm sharing a link for some Telegram groups. And usually those links for the channels will be, and for the talks will be shared on the Telegram groups and the WhatsApp groups. So please join those groups. Now, the next speaker is one of the serial offenders on those webinars. So Abir has been on those webinars quite a few times. It's always a pleasure to have Abir. And she's going to tell us about the pathology perspective from the TADPOLE point of view. Abir, the next 10-15 minutes are all yours.
Thank you very much, Yazan. It's a pleasure to be part of this webinar. And I would like to take you through the axillary examination from the pathologist point of view. As you know, axillary node pathology is important, and it's important to identify what's going on there, whether there is metastatic disease or not, for various reasons, and now particularly the number of nodes involved for the TADPOLE trial. But this is a prognostic, it's a component of multiple systems, the NPI, the TNM, the residual cancer burden if after chemotherapy, and it guides management, surgical and oncological. And as Nisha explained, the sampling of the axillary nodes is usually by core biopsy or fine needle aspiration. And we also receive either a sentinel node, axillary sampling, targeted axillary dissection, or axillary node clearance. We normally receive axillary nodes, but sometimes others, such as intramammary or internal mammary nodes. One of the tips I would actually recommend is to have a standardized breast histopathology request form, one for the core biopsies and one for the surgical excision, something that's agreed on by the whole MDT team to be all singing from the same hymn sheet. So we know exactly the orientation, what we're sending, any marker clip localization or non-wire localization, all the important information. And this is, as we heard, particularly important in the TADPOLE trial. And these are examples of the specimens that we receive. So sometimes we receive the axillary node clearance in continuity with the breast. Sometimes we receive wide local excision or mastectomy with a separate sentinel lymph node biopsy. For wide local, it's really always good practice to agree a standardized inking protocol. So it is, and standardized orientation protocol as well. So it is used consistently by the whole team. When we receive the surgical specimens, including the sentinel lymph node biopsy, we like to receive them fresh and confirm details and book them in, confirm orientation, any localization methods. We put them in formalin to fix and then do the macroscopic cut-up, usually 24 hours later after the specimen has been fixed well. When we examine lymph nodes, we look for all lymph nodes in the axilla, no matter how small the lymph node is, because the number is important and is prognostic. We palpate very well to find lymph nodes. Small lymph nodes can be put whole or bisected. Larger ones are sliced at 1 to 2 millimeter intervals, perpendicular to the long axis, and we always document the number of lymph nodes identified and the number per cassette. So this is just a representation of how we slice them. And 1 to 2 millimeters is important because that's the cutoff for the TNM classification of macrometastases. So 0.2 millimeters to 2 is the micromet, above 2 is macro. So if we ever slice above 2, then we will miss the metastases. So that's why we actually slice thinly and we put them in cassettes. And these are the cassettes before we process them. And the breast ones are normally in pink or red to be visible and to be processed very urgently. Sometimes when nodes are fully replaced by metastatic disease, there is very little nodal tissue remaining, and this looks exactly as the tumor in the breast. So sometimes it's very difficult to confirm if there is metastasis or it is a primary higher up a bit in the axillary tail, and we look for residual nodal tissue and also normal breast tissue or DCIS to confirm the origin. And sometimes we get other nodes, such as the intramammary lymph nodes. They are as prognostic as the axillary nodes, and we normally count them within the axillary nodes. So from the surgeon's point of view, we want the nodes orientated if possible, indicate the levels if you've done more, and indicate if post-NACT, although this doesn't apply to TADPOLE. And for the pathologist, we examine thoroughly and document the sampling and the number of nodes involved. If it is an FNA, we need to confirm nodal sampling and the pathology. For TAD, we would document the number of nodes, numbers with metastases, if there is any extracapsular spread, and the size of largest metastasis. And this is an example just lifted off from the latest Royal College of Pathologists guidelines on how to report lymph nodes, whether a sentinel node or a TAD or axillary node clearance. Measuring of metastasis can be a bit tricky. So if it is a wholly involved node like this, it is easy because you just take the largest dimension of the lymph node. Sometimes it's really small and we slice through, sometimes do immunohistochemistry to get the maximum dimension, and this is just a micromet here. Isolated tumor cells can be multiple and can be difficult to assess, but immunohistochemistry for pancytokeratins is very helpful in flagging them up, highlighting them. And as per the guidelines, we go for the largest metastasis. So we don't add these up together. If we add them, they will be probably a micromet, but we do levels, immunohistochemistry, and just measure the largest, and this would be the measurement to go by, and in this case, it is an isolated tumor cells. Sometimes it's not that straightforward and you have multiple coalescent foci. In this case, we would just take the maximum measurement. And immunohistochemistry can help, but it's not mandatory and it's done at the discretion of the pathologist reporting. Post-NACT axillary nodes, which this doesn't apply to TADPOLE, but we've learned a lot actually from examining the axillary nodes and localizing them from the neoadjuvant setting. In this setting, there is a decrease in the lymph node yield because they undergo atrophy, and you can see tumor regression. As Nisha mentioned, there are several ways of localizing the lymph nodes, and these are some examples that are taken from the ATNIC trial. And it's important that you communicate this to us, what method of localization was used, because we will accordingly look for it in the tissue. So it can, the commonest that we receive is the marker clips and MAC seeds, but also black ink is used by some centers because it's cheap and quick to apply. Complete response relies on the absence of any metastatic disease in the axilla. And generally, if there is neoadjuvant chemo, we would look for evidence of tumor response, fibrosis, reactive changes. And sometimes you have these very small residual cells among an area of regression. And residual cancer burden, one of the features of it and the parameters that we use for calculation is the number of nodes involved and the maximum dimension. Sizing can be difficult and the guidelines vary slightly, but it's always the largest focus of metastasis that is used for calculation for the TNM and the residual cancer burden. Intervening fibrosis is not included in the TNM, but actually is included when you measure the largest size by the residual cancer burden. And the lymph nodes remain prognostic, whether in treatment-naive patients or in tumors that underwent neoadjuvant chemotherapy. Just a word of caution that ITCs in the neoadjuvant setting have different significance from ITCs without treatment. So we recognize that ITCs, if there is no prior treatment, are regarded as node negative, but if they are positive, there are ITCs after NAC, this is considered resistant disease, and this is not regarded as PCR. And there is some discrepancy between the TNM classification of it and the UK guidelines in that, but it is regarded as residual disease and should be categorized as PCR. It's also important to examine the lymph nodes histologically because we can do all molecular markers on the metastatic disease as we do for the primary breast cancer, although the multi-gene assays such as Oncotype and Prosigna are not recommended to be done on the axillary node metastasis, but everything else can be done. So receptors, PD-L1, ESR1, PIK3 kinase, all of them can be tested on the metastatic disease. We need also to remember not all lymph nodes are either negative or metastatic breast cancer. We get benign inclusions, ectopic breast tissue, some inflammatory conditions, non-breast metastases, and some other hematological malignancies. So it is important to histologically examine the lymph nodes, confirm metastasis and number, but also exclude other maybe coexisting or other non-related lesions. And that's it from me. Thank you very much.
That's great talk, Abir, and it's great to see that overview. I'm sure there'll be lots of questions. I think the Q&A section is one of the busiest in all of the webinars. We already have 40 plus questions. So please have a look at that. I can see that Nisha and Shelly has answered loads of those questions. And now we have Stuart McIntosh, who's one of the academic surgeons in Northern Ireland, and Stuart has been involved in loads of the studies in the UK. And he's going to talk to us about adjuvant treatments for the surgeons, because there's lots of the discussions on to clear or not to clear based on adjuvant treatment needs. And Stuart is going to answer all those questions for us. Stuart, the next 10-15 minutes are all yours.
Yazan, thank you very much, and thank you for the invitation to speak. Greetings from, it is sunny in Belfast, but it doesn't look that mountainous, I'm afraid. But I thought it would provide a little distraction. Good morning, good afternoon, good evening, wherever you are in the world. And thank you. My first declaration, I suppose, is that I am a surgeon. I'm not an oncologist, and therefore perhaps I shouldn't be talking about adjuvant treatments, but I'm afraid you've got me. So here we are. I'm going to talk a little bit about adjuvant treatment, particularly in the context, as Yazan says, of axillary node dissection and how that relates to the TADPOLE trial. So you've already heard from Shelley a little bit about the lack of evidence for a survival benefit from axillary node dissection. And the other reason that historically we have dissected the axilla is to achieve local control, although as we all know, axillary recurrence is a rare, uncommon event, not often seen in contemporary practice. The other reasons for dissecting the axilla are both prognostic and to allow us to make decisions about adjuvant treatment. And as we'll see, these are two issues which are very much related. Now, in the context of decision-making about systemic therapies, we know that neoadjuvant treatment is currently the recommended standard of care in high-risk, early, triple-negative and HER2-positive disease. And I've seen a few comments relating to that in the chat. But for T2 or greater disease or for N1 or greater disease, neoadjuvant systemic therapy is the recommended treatment approach for these patients. So we anticipate that the majority of patients in TADPOLE, not all of them, it's not exclusively for patients with ER-positive disease, but we do anticipate the majority of patients are likely to have ER-positive disease, in which the primary treatment is generally likely to be surgery. And I suppose the question for us recruiting patients to TADPOLE of limited axillary surgery is to look at what is the additional value of axillary node clearance or completion lymph node dissection for making decisions about adjuvant treatment. And traditionally, we have used the number of involved lymph nodes both for prognostication and for decision making, and that's illustrated by the PREDICT tool. Many of you may be familiar with it, some of it may not be. It's an online tool developed in the UK which allows you to use clinical pathological factors to estimate relapse risk and potential chemotherapy benefit. And you can see that you can enter the clinical pathological criteria, so patient age, menopausal status, ER/PR status, tumor size, grade, and nodal status. And here you can see I've entered one node in this example that we're using, which shows us that this patient potentially gains a chemotherapy benefit of around 4% in this setting. If we tweak the numbers and increase that number of nodes to 4, what we see is that the chemotherapy benefit goes up from 4% to 7%. But what we also know, we do know that chemotherapy reduces recurrence and mortality risk in ER-positive disease in the same way as it does in ER-negative or HER2-positive disease. We also know, and I'm illustrating it with one of the forest plots from one of the many EBCTCG chemotherapy meta-analyses, we know that there is a modest absolute benefit from systemic chemotherapy, and the relative chemotherapy benefit is the same for all patients, regardless of their tumor pathology features. So regardless of T stage, regardless of nodal status, the relative benefit of chemotherapy is independent of these factors. The relative benefit doesn't change. The absolute benefit goes up because the absolute risk is higher, but the relative benefit does not change, and we need better ways other than just dissecting the axilla to identify those patients who will benefit from chemotherapy. And that leads me on to talk about gene expression profiling, which Abir has already mentioned. Question is, can we use this in the TADPOLE setting in PN1 patients who have not had a completion axillary node dissection? And the answer is, well, absolutely yes, we can. If you remember the RxPONDER trial, this was designed to look at patients with ER-positive, HER2-negative disease who had 1 to 3 positive lymph nodes, looking at whether or not Oncotype could predict chemotherapy benefit in this setting. What you can see from the RxPONDER table is that around a third of the patients in RxPONDER did not have an axillary node clearance. They had a sentinel node biopsy alone and did not go on to completion clearance. So you don't need to do a completion clearance to use Oncotype in this setting. And in this context, in the context of patients with PN1 disease with an intermediate risk recurrence score on Oncotype, there is no benefit from the addition of chemotherapy to endocrine therapy. So this is telling us we can use tumor biology in the form of gene expression profiling to assess risk and make decisions about adjuvant therapy. We don't need a completion clearance in this setting. As I've said, finding additional nodes does not alter the relative benefit. It only increases the modest absolute gain. And we can identify patients who can avoid or require chemotherapy without the requirement for axillary lymph node dissection. So the next question I hear a lot is, well, what about CDK4/6 inhibitors? We need to dissect the axilla in order to answer the question, does this patient require abemaciclib or ribociclib? So abemaciclib, based on the Monarch-E trial, which was looking at the addition of 2 years of adjuvant abemaciclib in high-risk ER-positive, HER2-negative patients, all of whom were node positive, and there was a survival benefit, an invasive disease-free survival benefit seen for the addition of abemaciclib in this setting, around 6% at 4 years, increasing to about between 7.5% and 8% at the 5-year point. So it reduces the risk of an invasive disease-free survival event in that time frame. And this led to the approval in the UK and in many other places in the world of abemaciclib in patients who had 4 or more positive nodes or 1 to 3 positive nodes with other adverse prognostic features such as T3 tumors or high-grade disease. So does this mean we need to start dissecting axillae to find these patients with PN2 disease? Do we need to hunt them down and find them to treat them? And this is the question that I hear being asked. We need to dissect the axilla to find patients with PN2 disease. Well, this question has actually been specifically looked at by a very elegant analysis from the CINEMAC trial. And if you remember, CINEMAC was a randomized trial comparing outcomes in patients who had a positive sentinel node biopsy randomized to no further axillary surgery versus axillary node dissection. And so patients in the sentinel node biopsy alone arm didn't have completion axillary surgery. We don't know how many positive lymph nodes there were. So they looked at this question. They took patients who were not eligible for abemaciclib under the Monarch-E criteria, i.e. they were T1 or T2, less than 5 centimeters, grade 1 or grade 2 tumors. And they looked at the group of patients who had a completion clearance for their positive sentinel node, and they saw that about 13% of these were found to be converting from PN1 to PN2 disease by virtue of the completion clearance. Whereas in the sentinel node biopsy alone group, only 1% of patients were known to have PN2 disease. So an absolute difference of 12%, say that 12% of the patients in the completion axillary dissection group were found to have 4 or more positive nodes. So that means, simple arithmetic here, that in order to find one patient with PN2 disease by doing a completion axillary node clearance, we need to dissect 8 axillae. So one PN2 patient requires 8 axillary dissections. Hold that thought, because what I'm then going to tell you is that the Monarch-E trial showed a 7.6% reduction in the risk of an invasive disease-free survival event from abemaciclib. That means you need to treat 13 people to prevent 1 IDFS event. So that means that the number of axillary node dissections you need to do to prevent 1 IDFS event is 104. That's a lot of axillary dissection, a lot of morbidity for our patients, as they also showed, because assuming a lymphedema risk of about 12.6, the number needed to harm is around 8 to cause lymphedema. So if we use axillary clearance for staging, we do 104 clearances, we cause lymphedema requiring treatment to 13 patients, and we prevent 1 IDFS event with our use of CDK4/6 inhibitors. Those numbers do not look compelling to me. And actually, this question may well become a moot point anyway, because in the subsequently published Natalie trial, which looked at adjuvant ribociclib for ER-positive disease, around a quarter of patients were node negative, and there still was an absolute 4-year IDFS benefit of around 3.3% seen. hazard ratio of 0.75, not wildly dissimilar to the hazard ratio in monarchy. So stop. We do not need to dissect the axilla to make decisions about CDK4/6 inhibitor, because that decision is not supported by the published data. The other thing to mention in this context is that we don't currently have data on how informative gene expression profiling is for making decisions about CDK4/6 inhibitor use, but we will get this in the near future, because the Optima trial in the UK, which is looking at the use of the ProSigna test in patients with PN1, PN2 disease, around 35% of the patients in the Optima trial will be eligible for CDK4/6 inhibitors. So it will give us information about this. And finally, to back up what I've just told you, there is good evidence to suggest that axillary lymph node dissection does not provide information that's being used to make decisions about adjuvant systemic therapies. And this comes from Walter Weber's TAXIS study, which is looking at tailored axillary surgery versus axillary lymph node dissection. And what they saw in the tailored axillary surgery arm, consistent with CENIMAC, is that there is significant understaging when axillary node dissection is omitted, but there was no difference in the use of systemic chemotherapy between the two arms. So additional axillary surgery is not influencing adjuvant systemic therapy decision-making in this setting. This doesn't include CDK4/6 inhibitor patients because it predates monarch-E, this analysis. So I want to spend the last couple of minutes talking about radiotherapy, and specifically regional nodal radiotherapy. This has been discussed at length, both among the TADPOLE trialists and in the Q&A section this afternoon, this evening. And if we look at the EBCTCG overview, looking at regional nodal radiotherapy, what we see in newer trials looking at regional nodal radiotherapy is that this does reduce the risk both of recurrence and the risk of breast cancer death. And if we look at subgroups, looking at breast cancer mortality here, the forest plot for recurrence looks very, very similar. As we can see, relative benefit is always fairly consistent across the groups. Therefore, the level of absolute benefit depends on baseline risk, which we know is going to be higher in patients with T3 or PN2 tumors or high-grade tumors. But if we translate that into absolute numbers, what we see is that there are small gains from regional radiotherapy in PN0, PN1 patients, and slightly larger gains, but still modest gains in both recurrence risk and in mortality risk in PN2 patients. And if you do the numbers once again to see how those stack up, the number of axillary dissections required to achieve that small benefit is going to be extremely small. So I noticed Shelley's already answered some questions in the chat around regional nodal radiotherapy and TADPOLE. We don't want TADPOLE to be a trial of targeted axillary dissection plus axillary radiotherapy. So we've made some pragmatic decisions to try and ensure that this doesn't happen. We've restricted the entry criteria to patients with T1 to 2 disease, taking out that T3 group who are likely to get regional nodal radiotherapy. We've restricted the entry criteria to only those patients with a low burden of nodal disease on ultrasound scanning. We've excluded lobular cancers, and we have radiotherapy QA, where, as Shelley has said, axillary radiotherapy is not permitted in either arm, although we accept that there may be a very small number of patients where regional nodal radiotherapy is recommended, and they may receive irradiation to their undissected axilla in this context. So I hope this covers some of the questions that I've already seen raised in the chat. The sun hasn't quite set in Belfast here yet, but that's what our office looks like when it does. Very happy to take further questions in the discussion. Thank you very much.
That's a great talk, Stuart. Lovely talk, covering lots of things that we always fight on in the MDTs. Now, some centers are doing TADs, and Henry Kane from Newcastle, they have done quite a few, and he's going to talk to us about the Newcastle experience. Henry, the next 10-15 minutes are all yours.
Hi, that's great. Thank you very much. I'm just trying to get my screen to share. All right, one moment. As always, you have everything beautifully set up and then it all disappears. So just give us 2 seconds.
The quickest you share, the quickest you go back to the match.
Don't even talk about it. I've got it recording, so I don't want to I don't want to know any of the results. So I'm trying to judge how grumpy Stuart looks. So I'll be there in 2 seconds.
Might turn off my camera then.
Yeah, don't there we go. Right.
That's perfect. You just need to make it a full screen and
Yeah, it'll just go in a second.
Perfect.
Great, excellent. So apologies for that slight interlude there. Thank you very much, Yasan, for inviting me to speak in this this great webinar. I think Stuart just perfectly weaponized the data for the argument we have with oncologists about the necessity to clear a axilla to provide them with some more sort of predictive information there. I think that was a great set of slides, and I've certainly have taken some photos of those ready for my XMDT. So I've been asked to give you a bit of an outline about our experience with doing primary TADs. I'm going to cover about where at Newcastle we started, how we did it, where did this get us, and what we're going to do next. And so I'm a breast surgeon in a mixed screening and symptomatic unit in Newcastle in the north of England. We treat about 650 cancers a year, split equally between screening and symptomatic cases. So we sort of realised that we were seeing a lot of patients coming through, about 1 in 4 patients with positive axillas on staging, and therefore we're doing axillary clearances as per all the guidelines at the time. But back in 2012, 2013, we started working with the Netherlands Cancer Institute on wireless breast localization, and from that we went on to use the radioactive iodine seed. But while we were over there, we got exposure to the Marie node procedure using the iodine seed to do post-neoadjuvant targeted dissections. And so we came back to the UK in 2014. We performed our first post-neoadjuvant targeted dissection. And then in 2016, we presented our first series of these operations, our first sort of 50 or so of those. But in the meantime, we actually started doing primary TADs, and these are exactly what we talked about today, patients with stage positive axillas, but not having a clearance in their first operation, but having one of these targeted dissections. And so what was our rationale of doing it? Well, at the time, it just seemed logic and common sense. We knew that post the Z11 and ASCO guidelines, we'd already begun to de-escalate our sentinel node positive patients. And so we were a relatively early adopter of those ASCO guidelines, saying 1 to 2 positive nodes, breast conservation surgery, getting adjuvant therapy, getting adjuvant radiotherapy, they don't require a clearance. So we'd already made that leap fairly early on. We had a commitment to the POSNOC trial, and that actually probably escalated some of our auxiliary treatments as part of the POSNOC trial. But towards the end of the POSNOC trial, they actually allowed patients who had primary TADs to go into the POSNOC trial during the last sort of 6 months of it. And so we felt that, well, if they're going to allow primary TADs, it's something that must be valid for us to consider. We had a problem in our unit, and the problem was our radiologists were getting really good at spotting very low volume disease in the axilla, and on the back of that we had a sort of over treatment and a high rate of 1 node positive axillary node clearances. So they would spot the tiniest little thing in a lymph node, put a needle in it, find cancer cells, and that was at the time was committing us to do an axillary node clearance. And so we had a set of patients who had the axillary burden of someone who had their nodes diagnosed on their positive nodes diagnosed on sentinel node biopsy, but having a significantly more aggressive surgical treatment of that axilla. And it just didn't make sense. We couldn't work out, well, if the patients who have their metastases diagnosed on a sentinel node biopsy were doing fine without a clearance, why would the patients who have their metastases diagnosed on an ultrasound scan and needle test have any benefit from having a clearance? And so that was the sort of premise that we had before starting it. And that's really why we sort of possibly jumped the gun with regards to where the evidence was at that time. So we introduced this as an audited treatment improvement plan, and we built on our learnings of neoadjuvant TAD. So by that stage, we've got a fair amount of experience under our belt of actually how to do the operations. We informed all our patients that standard of care would be an axillary node clearance in their setting, but then we explained that rationale to our patients of why we were considering de-escalating their surgery. And our criteria very much was sort of well aligned to what's being considered now in the TADPOLE study. So primary breast cancer, we looked at low burden disease. So we like to see only 1 or 2 abnormal nodes. It's great if we can see some normal nodes above them on the ultrasound scan. We wanted proven disease on the FNA, or more commonly core biopsy. These were patients who we weren't going to give neoadjuvant chemotherapy to, and so biologically these would tend to be ER positive, HER2 negative patients rather than your triple negatives or HER2 positives that we would be looking to give neoadjuvant chemotherapy to. They needed to be able to have radiotherapy to the axilla, and the patient consented to this non-standard of care treatment, but we always told them that if there is clinical concern during the operation, we would then proceed to an axillary node clearance on the table. We had no restriction on the volume or type of breast disease that they had. They could be having mastectomies, they could be having breast conservation surgeries, reconstructions, yes, no, all those sort of things there. We didn't really want to sort of tie anything down with regards to the actual breast cancer. So how did we do it? And again, very much in line with what's proposed at the moment in the TADPOLE study. We initially used the iodine seeds to localize these nodes. We then switched to a pin localizer. We used single agent technetium-99 and just use that alone especially if the signal in the armpit is good. We've got this argument that actually by localizing the node with a clip and the pin, that's one of your localization methods. So we talk about dual localization of axillary nodes. Well, you've already done one with a clip and a pin, and so the technetium is your second localization, localization technique. We did sometimes add in, not usually blue dye, but usually one of the ICG, the green dye that we use with the camera if we felt it was necessary. We tend to do more of an en-bloc resection of these lymph nodes, and so we'll go in, we'll identify where the hot node is, we'll then use the sentinel node probe to identify the next couple of nodes up from it there, and then we'll just go above those, sweep those down, and so we actually take a sort of a lump of fat with hopefully the 2 or 3 or 4 lymph nodes in it, and we found that was far easier than doing a more picked dissection, because if you're trying to do a picked dissection of a node with a clip and a marker in it there, it's very, very easy to displace that clip and marker. They don't stick in nodes as well as they stick into the breast there, and so that's why we go for more of an en-bloc type approach. We aim to take at least 3 nodes, which is 1 mark node plus a couple of sentinel nodes above it there, and we obviously put these in a FACSitron, confirm that we've retrieved the marked node. This was the very first case we did. It's actually a post-neoadjuvant targeted dissection there, and it was mentioned earlier about sort of wireless localization. We did the first couple with guide wires going into the lymph nodes, and they were tricky. They were awkward, and we were absolutely delighted when we were able to move away from the guide wires and use our non-wire localization. And so this is a specimen X-ray of a wire localized one. You can see the little twirl clip in the lymph node there, and a couple more lymph nodes on the specimen X-ray there. And then this is one that's more probably contemporary, where we've got a marker in the lymph node there. These are nice markers. They sort of expand up a bit, and they're quite easy to see with the ultrasound probe. And that's got a pin next to it, and so that's the sort of resection. So then obviously we're doing this as part of an audited study there. We want to know what our outcomes were. And so we looked at our outcomes from 2016 to 2023 as our most up-to-date cohort. And there we've just taken every consecutive primary TAD we've done in that period of time. And up until the beginning of 2023, we had just about 100 patients in there. So we had 99 patients. The age range, we didn't restrict on age range. We do this in young patients and old patients. The median tumour size was 34 millimetres. We had 13 patients with multifocal disease, some patients with really big cancers. And as you'd usually expect in the split in a unit of our sort of makeup there, 75%, 76% were breast conservation surgery, the rest were mastectomy, including some immediate reconstructions. Looking at the biology, the majority were ER positive, HER2 negative, as you would expect, because if they'd been triple negative or HER2 positive, they would have had neoadjuvant chemotherapy. And 95% were diagnosed on core biopsy rather than FNA. So there were some cases that intraoperatively we switched to an axillary node clearance. There are 4 cases out of the 99 there, and 1 patient we probably did it unnecessarily, and we took out 16 nodes and only 2 had disease in. But the other 3 patients there, we had 1 which was 2 out of 4 in the TAD, and then a further 8 out of 10 on the clearance. The 3 and 4 we've only got reported of clearances, and they had obviously fairly heavy disease. We always like to say, oh well, these will be the lobulars, because the lobulars are difficult to stage preoperatively, but actually all of these were ductal cancers that we switched to clearances intraoperatively. What about our successful TADs? Well, we had 95 completed as planned. We took a median of 4 nodes with a range of 2 to 12 nodes there. And you can see that the vast majority of patients remain as either 1 node or 2 node positive. And so 71% of our patients only had 2 nodes as their total nodal burden. And if you think that, if these patients had been treated with a clearance, the vast majority of these would have been cleared, where if they had treated with a sentinel node and found to be positive, they wouldn't have had any further auxiliary treatment. And in total, 80% of these patients were N1 following their primary TAD. Talk a bit about negative denominators here, and this is something that we're quite keen on, because what we want to know is, are we leaving a tremendous amount of residual disease behind? We only had 1 patient, which was a 1 out of 1 TAD, and we gave them some radiotherapy. So we had 1 patient, which was a 2 out of 2 TAD. We went back into the clearance on that patient, so final stage was an N2 disease there. And then we had 3, which were 4 out of 4 on their TADs, and we went on and cleared all those patients. So in only 5 cases, we failed to get that negative denominator to give us the reassurance that we weren't leaving excessive amount of diseases before. We didn't happen to have any patients which were 3 out of 3 positive. So what about the patients who turned out to be N2 after their primary TAD? So we had 17 patients which were N2 on the TAD, so that's more than 3 nodes. And 11 of those patients we went on to clear. 4 of those patients had radiotherapy, and they were actually the ones that we'd obviously done a fairly healthy TAD, and we'd taken 10 or more nodes in the targeted dissection, and so we just gave them radiotherapy. We had 2 receiving radiotherapy due to comorbidities. What happened about the patients that were N2 and we did a clearance on there? 4 of them then went on to have a negative node, and that included the 2 patients who were actually 4 out of 4 on the TAD. They had no further disease in their axilla, so I'll let you sort of read into that what you will. Only 1 single patient was upstage from N1 on the TAD to N2 on the clearance. 2 patients remained N1, and 9 patients were already N2 on their TAD, so they didn't actually change nodal pathological staging following the clearance. Of interest there, we had 3 patients that we wouldn't necessarily stage all node positive disease preoperatively, especially if it was a relatively small indolent cancer and it only looked like they had 1 node on their axillary ultrasound scan. And so we had 3 patients that they had N2 disease on their TAD, so they underwent staging before we went on to do their clearance, and actually the three of these patients were found to be stage 4, so metastatic on their staging. So obviously we didn't go on and clear their axilla once we had the knowledge that they were already metastatic. So the further auxiliary treatment, the majority of our patients who didn't have clearance, we gave auxiliary radiotherapy for. That was our sort of our safety net there. We've got multiple studies that showed radiotherapy is equivalent to clearance. So we referenced things like the Amaros study there. And so we felt our reassurance to the patients and our oncologists and ourselves was that we would be giving some form of further auxiliary treatment to these patients who didn't have a clearance. 8 patients following the TAD didn't have any further treatment. 2 of these were actually in the intervention arm of POSNOC, so they were taken out of treatment in a randomized control trial. 6 of them didn't. There were 5 patients who were 1 node positive and more than 4 nodes taken. We felt very confident in admitting any further treatment in those patients there. And there was 1 patient who was 2 out of 6 on the TAD, and with discussion with them, they decided that they didn't want any further treatment. We had 1 case where we failed to find any disease in the axilla, and we've looked at this fairly extensively because obviously when you do a targeted dissection, you expect to find some cancer in 1 lymph node. We're looking back at this there, she had 1 N3 node on ultrasound scan, and the FNA was actually reported as an LN4 atypical cells. Now, usually we'll go back and biopsy this, but the patient didn't want any further needles putting in her. So what we decided to do was to do a TAD on her rather than either say, well, it's LN4, we'll do a clearance, or LN4, we'll just do a sentinel node biopsy. We had the option of doing a TAD. So we did a TAD, and we took the hot node, which was actually the iodine seed mark node, took another couple of nodes on sentinel node biopsy, and she was actually 0 out of 3 on pathology. So we had a big discussion, what were our options? There was either no further treatment, radiotherapy to the axilla, or go back and do a clearance. And the patient actually elected for radiotherapy, which we were happy to support her with. So what have we learned? It's certainly feasible to see it significantly de-escalate surgery. So we had 88% of our patients avoiding axillary node clearance, and 80% of these patients were truly N1 disease. The vast majority only have 1 or 2 nodes involved there. We've got a median follow-up of 3 years and no axillary recurrences, but then we know axillary recurrences are incredibly rare in any situation now with modern adjuvant treatments. We do sort of favour the en-bloc approach rather than trying to pick individual nodes. It gave us a very low failure rate, which was probably actually 0 in this series. It gave us a low failure to gain the negative denominator, and it gave us a reasonable median node harvest of 4 nodes, which we didn't think was too excessive. So what's our view on TADPOLE? We think TADPOLE's a really, really important trial, and it's vital to get this sort of data for units where there is resistance to de-escalate axillary treatment. In our case, it would actually represent an escalation in axillary surgery because we're TADing all these patients anyway. And so if we put our patients into TADPOLE, a third of them would have an axillary clearance as part of the randomization. So it would be what we feel is an unacceptable axillary escalation of surgery in our practice. We feel that the negative denominator is essential, especially when considering de-escalation of radiotherapy, which at the moment in our practice is standard of care in these patients there. So we actually won't be putting patients into TADPOLE, but we're going to be desperate to see the results so that we can stop giving the adjuvant radiotherapy to the axilla in the patients that we have done a primary TAD. And until we've got this evidence from TADPOLE, we don't think we're able to take that final step of omitting the radiotherapy, which I think is certainly where we're going to end up. But we just need this trial to run and recruit well. And I think I'm going to leave it there then, Yasin.
That's perfect. So we're on time, which is great. We are on time, so we have half an hour of discussion. It's great talks to cover everything. Now, remember, in this webinar, in the next couple of webinars, we're exploring things that might become the future. So this is not standard of care yet. There is data, but there is not enough data. And that's why Shelley and the team is wanting to run the TADPOLE, because some people say that, okay, the Z11 patients did not have scans. So many patients, if you scan them, they would be 1 or 2 nodes positive. So if you look at that sub-cohort, that might have partly answered the question, but it's difficult to answer the question with data and get that. And the most important thing for me, I think, is that when we de-escalate surgery, oncologists escalate and they give other stuff. And I think the brilliant thing about the TADPOLE is de-escalation of all treatments. We are not only looking at de-escalation of surgery. Any comments on that, Shelley?
Thank you, Yazan. Yes, I think TADPOLE is actually internationally novel in that the TAXIS study run by Walter Weber is looking at targeted axillary surgery, but all patients having the targeted surgery also have radiotherapy. TADPOLE is the only study worldwide looking to see whether TAD is sufficient local regional treatment for low volume nodal disease. So we're really excited to be running it.
And that's great. And it's very important. It's a teamwork. It's not only surgical trial. And that's why we have radiology. That's why we have pathology. That's why we need to have the oncology perspective. Now, in my own books, if you need to do something like that, you need to know your data for your radiology. If you're having negative ultrasound scans and you're having 40% positive axillas with negative ultrasound scans, then you need to start thinking twice about doing target dissections. So you really need to know your data before. Nisha, any comments on that?
Yes, I mean, what you've got to remember is that it depends on the cortical thickness that you're using to determine if a node is abnormal or normal. So in the guidelines, we state that you can use local practice, but normally a node greater than 2 millimeters cortical thickness could be deemed abnormal. So what that means is that if you have a 4 millimeter cortical thickness cutoff, then you will miss macrometastases that may only be 2.3 millimeters. So when you do sentinel lymph node biopsy, of course, you're going to have false negative cases from axilla ultrasound because your threshold for biopsy is much higher. And these are audits that local departments will have done to determine the cutoff and play with the fact that the sentinel node could be positive, but it shouldn't translate to an axillary node clearance. And in the UK, we're looking to standardise the cortical thickness where we should be needling the nodes that we consider abnormal. So we're currently doing the avoid audit, which we finished collecting data and are planning to analyse, and then we'll share. So we need to standardise imaging so that we can ensure that we're doing the right procedure for all our patients, regardless of which hospital we walk into.
And that's another key point in TADPOLE compared to other studies, standardization. It's not, yeah, come and join, and yes, do whatever you want to do, and yes, this is the results. Everybody will be doing the same, and which is very important. Abir, standardization. We always think about pathology about the same thing, but I think pathology's assessments is different. Now, I always think about a node. If you have a bean-shaped metastatic in it, for example, which is micromets. If you cut it in certain way, you might see it as two isolated tumor cells, and if you cut it in different way, it might look as one big micromet. Any comment on the assessment, and any comment if there is difference between the different parts of the world, how we look at nodes?
Yeah, so similar to radiology, standardization in pathology is really important because the rate of our positivity will depend on how we deal with the lymph node, how we slice them, how we interpret them, how many levels we do, whether we do immunohistochemistry or not. And sometimes it's really tricky. It's not easy to measure the metastases. So for example, there are some differences between the European, UK, and the US guidance on measurements of certain metastases, the ITCs, for example. So these are, as per the TNM staging, considered node negative, in brackets, I positive, isolated tumor cells. While in the UK, these are regarded post-NACT as positive. So positive node. So this is a big difference because they are regarded as resistant disease. Also, how you measure multiple close foci of metastases in the lymph node. So there are European guidance to say a cluster has to be about 200 cells, but how close is close to say that these are actually one? And this can differ depending on how you deal with the cases. For example, invasive lobular carcinomas can be difficult as well. And as you say, you can get the metastases in different slices. If you add them together, this will be the largest dimension in this, but if you only take one slice, it will be a much lower one. Another difference is the practice of techniques used to identify the metastases. And one of the colleagues in the chat has mentioned frozen sections. Frozen sections of lymph nodes is almost obsolete in the UK. We never do it, and we certainly wouldn't do it for neoadjuvant chemotherapy. But actually, you will be surprised, it is done in many parts of the world because they need to know intraoperatively the nodal status, and we know that it suffers from low specificity and sensitivity and false positive rate. So there are lots of variables in how pathologists and surgeons approach the intraoperative assessment and also sizing and reporting nodal metastases.
Perfect. I can see many people sharing their emails on the chat function. There is no point sharing emails on the chat function. If you want to be on the mailing list, either use the WhatsApp groups or use the Telegram group, or you can join the subscribe to the newsletter. So no need to put your emails on the chat function. Great answer, Abir. And there's quite a few people that are from the States and from other parts of the world and from Europe. Now, Stuart, it's always refreshing to have an oncology talk by a surgeon. It makes sense.
I'm not sure about that, but I'll take the compliment.
So you have answered that, and you can see the comment from Ian Brown online to say this is the most sense-making. It makes lots of sense, and this is the thing that he takes to his MDT next time they're going to discuss about using CDK4 inhibitors for this. Now, CDK4 inhibitors will be answered because part of the answer is coming from Natalie and other studies. I think radiotherapy and de-escalation of radiotherapy is the major issue here, and I think that's the major bonus of this study. Any comments about that, Stuart?
No, I mean, I would agree with you, and Shelley is absolutely right. This is internationally novel. This will be the only study which will look at de-escalating radiotherapy in this setting, which is why we've gone to such lengths to work with our clinical oncology colleagues and develop the radiotherapy quality assurance manual and guidelines for the trial to prevent that from happening.
Perfect. And
I think as you alluded to at the very beginning, it's really important to make sure we're not de-escalating surgery only for somebody else to escalate something else. This is about individualizing the level of treatment and the treatment burden to the patient's individual level of risk.
And it's also important to know data before venturing into something new. You don't want people from all across the world to go and do a target dissection on axilla without knowing their data and leaving lots of positive axilla. So it's very important you know your data. And for example, where I work, we don't do target dissections for positive axilla. We are going to start hopefully doing that once we join the study. So it's always great to be part of a trial or part of a study to standardize the procedure, and also to have that cover and protection that you're doing something that is reasonable thing to do. Now, Henry, I'm sure it has been a bit difficult to start doing this because I think you and the Mazen were one of the first units in the country to do that up front. How did you? I know that I've talked about your experience in Newcastle, but what was the most challenging thing to start this?
We're quite lucky in Newcastle. We've got some fairly progressive oncologists, and we've got a very tight group of surgeons who all are relatively sort of similar in our outlook of the treatment of breast cancer. And so we were lucky from that respect there. We just presented, I think that there's been 3 or 4 comments about know your own data. And I think that's absolutely vital. We were able to sit down and say, right, well, what happens when we do this? So what's our false negative rate of our ultrasound scan? We know that we were only getting, of all our patients who had an ultrasound scan of the axilla, only 7, which was reported as normal, only 17% of them would actually have anything in the axilla when we did a sentinel node biopsy. And so we knew that, if they said that there was going to be low volume, we know that we've got really, really good radiologists scanning axillas. So we were very confident when they said, look, there's only going to be 1 or 2 nodes in this axilla. There will only be 1 or 2 nodes. They're very, very good at spotting when there's going to be N2 disease in the axilla. And so we felt very comfortable that we had an accurate way preoperatively of identifying these low volume disease patients. The second thing is, okay, well then look, what happened when you did go and clear these patients? So when the patients did have a sentinel node, so you need to know what your residual nodal burden is of the patients that you did a sentinel node on and went on and cleared. And we found that the vast majority of the patients, as we knew before moving to axillary conservation after a positive sentinel node, would either have nothing in their axilla when you did a completion clearance, or maybe 1 or 2 nodes, but they very rarely went up to the N2. They very rarely switch that nodal staging group. And so you need to know your own data. You need to know what's your false negative rate of your scans, and what happens if you do clear after a positive sentinel node. And then we just have that that logical discussion of, okay, well, if we're diagnosing very, very low volume disease preoperatively, what are the benefits in changing the operative plan? And one of the suggestions is like, well, let's just stop doing auxiliary ultrasound scans and do sentinel nodes on everybody, and then just react to the sentinel node biopsy result. But our worry there is, okay, well, there will be a few patients that will have lots of lymph nodes in the axilla, but there just didn't seem to be the logical answer not to do this. We were very, very conservative. We were going to keep all our results there. We audited our results. We kept an eye on everything. We knew what was happening. We knew the vast majority of patients we were doing it this to were ending up just with 1 or 2 nodes positive on their TAD and remaining that. And so it is. We're very lucky. We're lucky that we can be a bit of a sort of a pioneer in this. But everything's been done under a quality improvement, with active audit, with active reviews of it, and with the with the publication of our results.
And you get that, I agree with you completely, Henry. And you get that comment from some people, why to scan the axilla? Don't know if it's a positive node. Then you do a sentinel node biopsy. You find 1 or 2 positive nodes, and then you apply the Z11 criteria, which I don't agree with. I think more information is important information. And if you know before, then you run this study, then you will have more accurate way of dealing with this.
Well, you also don't know your tumor phenotype at that point, Yazan. So you need to know if this patient is node positive, because if they're HER2 positive or triple negative, then you're going to be going down the neoadjuvant route. So why would you not want more information? It makes no sense to me.
Exactly. And many people argue about this no information. I don't agree with it. Remember, as Stuart mentioned, and as also Shelley mentioned, triple negatives, HER2 positives, positive nodes, they need to have neoadjuvant chemotherapy. It's unlikely for them not to have neoadjuvant chemotherapy, except for certain subtypes of triple negatives that are chemo resistant, for example. So not all triple negatives are triple negatives. So this is mainly for the ER positive tumors. And I think it will be a game changer, hopefully, in the future. But I don't want people, because we still have 650 people online. We had 720 at one stage from more than 100 countries. I don't want people to go to their MDT next week and say, I want to do a TAD on this ER positive tumor just because I had a webinar online about this TADPOLE thing. Please know your data first, and please contact us, and please join. I already have a couple of texts from National Cancer Institute and Bahia in Egypt, and a couple of other centers, and those are big centers that they can be part of this. That will be great. Any comments from any of the speakers and panelists?
Yeah, I was just going to say that if in 2016 we had the TADPOLE study, all our patients would have got into the TADPOLE study. So it's nothing to do with, you know, we're not recruiting to it. It's nothing to do with the study itself. If that had been available for us in 2016, without doubt, every one of these patients would have been in it.
And well, that the main idea from this webinar is that Shelley and the team want an open international study. So we don't want this to be a UK only study. And it's great to have that people from Australia and Ireland be part of this, but we want people also from other parts of the world. We'll see how things will work. It might be difficult sometimes to do all the paperwork, but I'm sure if there is a will, there is a way. Perfect. Any other comments from anybody else? Because Stuart will kill me if he does not watch the rest of the match today. Any comments from anybody else? So this is a more focused webinar about one thing, and I think that we might be part of the future. So it's great to have you all here with us today. It's great to see the amount of questions on the Q&A section. We had 60 plus questions, and most of them were answered, which is great to have everything answered. Now, the next webinar is in 3 weeks' time. It's a slightly different format. We don't want to keep on doing the same format. The next webinar, what we'll have is 2 or 3 areas of controversy. We'll start with questions to the participants, then we'll give you the evidence, and then we have questions after that, and see if we have managed, by showing you some evidence, to change your mind. So we're trying to do something slightly different in the next few webinars, looking at things that we are used to do, but that doesn't mean that we are doing it correctly. Now, for Shelley, Nisha, Abir, Henry, and Stuart, you have been fantastic. Thank you for being part of this. For everybody online, this will be on the YouTube channel. Please join the WhatsApp groups and the Telegram groups. I will share the links. If you want to be part of this study, you will see the QR code on Shelley's presentation. If you don't have it, just email me and we'll let you know about that. And many thanks for being part of this. So for people in the States and South America, have a lovely day. For people in Europe, have a lovely evening. For people in the Far East and the Middle East and the subcontinent, have a good night. Thank you, everyone.
Thank you.
Thank you.
Thank you, Tatiana.
Thanks, Suzanne. I think that went really well.
I thought that did go really well.
Thank you. Thank you all. We still have 500 people online.
Very, very engaged audience.
Yeah, lots and lots of questions.
Yeah.
Lots of questions this time. I usually leave it till 2 hours, but today I think because it's focused, we have managed to cover everything. That's why we're closing early. And have a lovely evening, everyone.
Thank you.